Good afternoon. I want to welcome you to UCSF Family Community Medicine Grand Rounds. My name is Margot Venner, and I am absolutely thrilled to welcome our presenters today. We have a fantastic Grand Rounds in store for you, but first, just a few housekeeping announcements. Just so you know, the session is being recorded. Also, this is a webinar style presentation, which means that if you have questions, which we hope you do, we'd encourage you to enter them in the Q&A, and we will either do our best to answer them right then and there or answer them live, but please do use the Q&A. We'll also be sending out a session evaluation form if you'd like to fill that out. That can help us give feedback for our presentations for this time and for the future. And also, if you missed previous Grand Rounds, or if you just want to go back and watch this one again, all of them are recorded. You can find them on YouTube on the UCSF Family Medicine website, and they will be available probably Tuesday for this. It usually takes a couple days to upload. So I'm incredibly excited to welcome our presenters today. The title of our talk today is Redefining Global Health through Structural Competency and Allyship. Our presenters today are Dr. Sundeep Gupta, who is a family community medicine faculty member at Natividad. He is past CDC Director for Uganda, Malawi, and Zambia. He completed his residency in family medicine at Natividad, joined the CDC's Epidemic Intelligence Service as a disease detective, and then worked with them for 12 years with the CDC in 12 countries throughout Africa, Asia, and Central America, leading responses to HIV, Ebola, and other epidemics, while working in partnership with the host country colleagues to strengthen their public health systems. He also worked with UCLA and partners in HOPE and other local organizations in their efforts to fight the HIV epidemic. He's published over 50 manuscripts and provided public health leadership across different cultures and types of public health systems across the globe. In addition, we are welcoming Professor Adres Malata today, who is a PhD and is the Vice Chancellor of Malawi University of Science and Technology. She's also the former president of Africa Honor Society of Nursing and Sigma Theta Tau International. She's the former vice president of the International Confederation of Midwives and former principal of Kamuzu, I'm apologizing if I pronounce this incorrectly, College of Nursing, where she spearheaded it to become a WHO collaborating center for interprofessional education and leadership. Her list of accomplishments goes on and on, so I'm just going to hit a few highlights. Dr. Malata is a renowned international speaker, author, and editor of various journals in the field of health, nursing, midwifery, and the health workforce. She serves on various international, regional, and national boards. In particular, she's an advocate for girls and women's empowerment through education. Her research work focuses on maternal and newborn health, quality of care, health workforce, innovation, and technology. In addition, she has received a Doctor honoris causa from the University of Oslo in Norway. She has an honorary award of the Doctor of Nursing in Australia, and she is a Global Health Fellow at the University of California, San Francisco University, and the list just goes on and on. She's done such impressive work. We are delighted that she's here to share with us today. And in addition, we have Dr. Jason Chen, who is a PJY1 resident in family medicine in Natividad, who will be helping us answer questions. Again, the title of today's talk is Redefining Global Health through Structural Competency and Allyship, and I am delighted to welcome our presenters for an exciting session. Thank you.
Thank you very much, Margot. Let me just share my screen. Okay, hello everyone. Thank you so much for the opportunity to speak at the Grand Rounds today. We're really excited to be here. I will start out and then turn it over to Dr. Malata, whom I'd like to thank in advance for being able to join us despite the 9-hour time zone difference at the end of her work week. To be upfront, my overall goal is to relate what I wish I had known before I started my global health career after finishing my residency here in Natividad. And would have helped me avoid some of the mistakes I did along the way. So The title of this talk, of course, is Redefining Global Health. And I thought it'd be useful just to start off with a little bit about, from a passive voice, maybe perspective, how and why global health gets redefined. And it's not difficult to imagine that there's quite a few forces pushing global health over the decades to constantly be redefined, having started off really during colonial times as tropical medicine. And still those sort of efforts that have become more neo-colonial, the bilateral efforts, so meaning country-to-country assistance, usually from Western countries, really dominate global health. And they really represent a paradox where there's been incredible technical successes and millions of lives saved, but it's also a framing of a historic power imbalance that continues. In addition, there's multilateral efforts. And here I'm referring to really the global ones through the United Nations, as opposed to regional ones. This is where many countries pull resources to assist one country. So regional ones are like the European Union or the African Development Bank. And the global ones represent this aspiration for equity in global health, but have seen a bit of ambivalence and waxing and waning in funding for global health actions in many countries. And then in addition, of course, there's constant changes in governance, economies, and health systems within low and middle income countries. Of course, the world is always changing, and global health will continue to constantly be redefined. Some key themes these days are China's greatly expanded influence around the world, a rapidly growing private sector in many low and middle income countries, and we've seen global health change very dramatically in Latin America in the last couple of decades because of this. Also, the bursting of the illusion of the West's sort of moral and public health leadership over the last few years is a key change. And along with that, there's a greater recognition of many lessons to be learned more from low and middle income countries for high income countries. A few years ago in a Washington, DC bi-directional HIV conference, domestic US HIV experts met with African HIV experts, and it was quite stark how many lessons were going from south to north versus the opposite. And then, of course, probably the way global health gets changed is voices calling for change, voices from low and middle income countries, from the diaspora that's grown over the decades, in high income countries and allies, and through activists and academia like here at UCSF. From a more active voice perspective, how can we redefine global health? I think it's important to start off with recognizing that, unlike hypertension, global health really is a different experience with a different perspective when talking to individuals from higher, low and middle income countries. And of course, this is just inherent in the power imbalance, which will realistically, as much as it's wrong and we need to always articulate and recognize that, will realistically stay there for the foreseeable future. So then the question becomes, how do we minimize the gap between different experiences of global health? Here, I believe it's important to really take a lesson from the anti-oppression and anti-racism movement that's really become quite solidified in the last few years, that there is no neutral, and the path out of neocolonialism is wherever we can to be actively anti-colonial. But to do so requires definitions to ensure accountability, which would require establishing milestones and standards at different levels, at the country level, funders, institutions, and more within our sphere of control ourselves. So these are really the ways that we can improve global health and redefine global health by improving the way we engage. The background diagram here is from the Canadian Institute of Health Research, similar to the NIH, where their new strategy is moving in this direction. I wanted to start off just with these two slides, just to get everyone thinking a little bit, and then take a step back and return to how we engage in global health. And I wanted to take a step back to talk a little bit about what global health looks like practically on the ground. Global health is a very unusual, nonlinear, ambiguous career track. And my career path went through the Epidemic Intelligence Service, and then to CDC, and then with UCLA, seconded to a local organization in Malawi. And it can be hard to visualize what global health can look like. So I'd like to provide a framing for that. And I'll start off with vertical initiatives. This is really where the money is. So if you are building a career in global health, there's a very high likelihood that you'll be funded through a vertical initiative. Those are disease-specific initiatives. That was the case for me through most of my career. It's striking that of all health overseas development assistance, it's all foreign assistance in health, 40% of it is through US global health dollars. So the US is really an outsized player as a percentage of the overall pie. Looking at a per capita basis is a bit different, but just for the overall pie. And if you look at the pie chart, you'll see that almost all of that funding is vertical funding. So this implies different officers in US embassies, different NGOs funded through different vertical disease-specific streams, and different sets of metrics and reporting to Congress. There's a few framings. I have a number of triangles or pyramids throughout this that for me have been helpful for framing, looking at aspects of global health. The one on the top right is from the UNAIDS, and that's what UNAIDS promoted at the beginning of the HIV epidemic response, what they call the 3 1s. And it's a useful framework for thinking about what a successful vertical or other kinds of responses should ideally look like. This includes one national coordinating authority, one national monitoring and evaluation system, and one national action framework. It becomes quite clear when you're in an environment, whether it's a community level or a national level, when those exist and then they don't, how coordinated or efficient the response is or is not. Another framing is implementation, either emergency through relief programs or longer term development through programs, and then learning lessons in a systematic way, whether that's well done monitoring and evaluation or research, so it's the science, and then using all of that information to inform policy, which then changes the relief or programs that are being implemented on the ground. And organizations that work in all of those, across all of those, tend to be well respected and probably more impactful than those that work in just one. There's a lot of course, global health organizations working at many levels, and the green triangles throughout this presentation represent that for the different kinds of initiatives. For vertical initiatives, working at a local level, like small NGOs or mission organizations, subnational levels, at a district level, or national level interventions, which tend to be more funded through bilateral or multilateral programming. So vertical initiatives are very interesting. And I mentioned the paradox earlier, that there have been incredible successes and millions of lives saved, but there's also challenges. And I'd just like to illustrate that with a couple of examples. First, we have Ebola. Ebola is, it would be hard to think of a more clear-cut case for a vertical initiative. We have an emergency infectious disease outbreak, very high mortality, widespread disruption of society. We're to the point where it's actually acceptable but tragic for hospitals to close down and other health services to suffer, in fear of spread around the world. The images on the right are from an MMWR from Liberia in 2014, showing that over a 6-month period, as we got faster at responding to hotspots when a new suspect case was communicated in a rural part of Liberia, that the duration of the outbreak also got shorter, and not shown on this slide, also the number of deaths and the number of cases decreased. And this illustrates a few different things. One, how the intensity of a vertical initiative can produce incredible results. With the other frameworks I mentioned, this is also an example of implementation, publication through science, and in a rapid way so it can affect policy in other countries fighting Ebola. And it's also an example of the 3 1s. You'll see the very long author list headed by the Liberian Ministry of Health. And it was a very coordinated environment where these kinds of actions could happen effectively. Another example is maternal mortality. Here we have something that seems like it would be great for a vertical initiative. And there was a wonderful initiative, wonderfully ambitious initiative called Saving Mothers, Giving Life, funded through the US government, which was an ambitious effort to tackle a difficult problem. So maternal deaths maternal mortality rates are quite high, but they're difficult to tackle because they're uncommon events. And there's been incredible progress reducing infant and child mortality, but for maternal and neonatal mortality, it's been more difficult. So if you're in a given hospital, it may not be that common that there's actually a maternal death. So this effort was a very intensive, ambitious effort, which was very successful. It was in Uganda and Zambia, and MMR, maternal mortality rate, was decreased by 41%. However, the cost was very high per death averted, and most of the investments were in health systems elements like the maternity waiting homes shown here in the background, or ambulances or staffing. And so there was a good discussion about that the money could have probably be spent better with a more broader impact. This funding was not sustained, so it was very useful as a proof of concept. But I think the take home here is that for this and many of the items in the pie chart I showed earlier, that the vertical initiatives are that a health systems approach may be better if done in the longer term. So this takes us to the next kind of initiative, horizontal initiatives. And I was very fortunate to be able to be very involved in health system strengthening initiatives. So horizontal initiatives work across health conditions. The backstory here is that when PEPFAR started, so PEPFAR is the President's Emergency Plan for AIDS Relief. It was a wildly ambitious, incredibly successful program that started under 2003 under President Bush, and has continued through every administration since to fight the HIV epidemic. When that started, it was very successful, but after a few years, there was a recognition that the health systems in many countries were being skewed. So healthcare workers and space were taken up for fighting HIV, while other life-saving services actually got reduced. That resulted in quite a bit of global soul searching and analysis. And this was right around the time in 2009 when Ambassador Eric Gooseby, who's actually a UCSF faculty member in Department of Medicine, became the new PEPFAR ambassador. And he had a great interest in health system strengthening. And for that 5-year period, there was quite a bit of energy around health system strengthening before the funding died out. One of the analyses that was helpful was from the World Health Organization, that's still a very strong proponent of health system strengthening, in their building blocks that are on the left here. For me, this experience was quite transformative. It really affected my sense of identity as a family medicine, as a family practitioner, and a public health practitioner. The related concept for the building blocks is here on the right, and this is the last mile. So the last mile is an old concept that's used in fields like electricity and relating to tree trunks or rivers or arteries and veins. That it's a basic idea that at a central level, there tend to be high capacity, long distance conduits. And at the local level, whether it's a household or a clinic waiting room or a clinic room, there's low capacity, short distance conduits. And the idea here is that these building blocks, health workforce, that's all of us and how we're trained and produced, financing and products and information systems, all come together and create the environment that establishes that patient encounter. And that can happen well different ways through the public sector, private sector. But also what's important is that in the blue oval, that the way those come together in country affects the performance characteristics. So the performance characteristics of a health system include access, coverage, quality, safety, equity, acceptability, feasibility. And when the health system is being strengthened, there's opportunities to influence that based on the culture and the priorities of a country. So in Malawi, we were, as part of the technical working group with the Ministry of Health, supporting decisions that were prioritizing equity and coverage over quality. In the United States, the healthcare system does the opposite. And this is another example of opportunities for learning lessons from low and middle income countries, but also thinking about how we invest our money in global health. At a local level, this looks like community-based primary healthcare, while there were a lot of other health system strengthening initiatives that were implemented. These are a few of them. It was very sad in 2014 to see the funding disappear for some of the wonderful global initiatives at the WHO level, like the Health Metrics Network and the Global Health Workforce Alliance. In Malawi, we were able to support the initiation of an obstetrics residency and a family medicine residency through these funds. And one of the most gratifying experiences I was lucky to be involved in was working on the Nursing Education Partnership Initiative. And I found this old slide that Dr. Malata was presented from about 10 years ago. And this is where I was fortunate to meet Dr. Malata, who I learned a lot about health system strengthening through this experience. And I'll let her talk more about that. The other thing I would mention here is that you'll notice that these images are different than the Saving Mothers Giving Life initiative, where you see a picture of a mom and a baby. And one advantage and disadvantage at the same time of vertical initiatives is that they are very marketable. And I do want to acknowledge that global health is a business. There's a commodity being sold. When you, and I looked at this before this talk, if you go to the USAID website or the PEPFAR website, you'll see lots of pictures of moms and children, brown or black, that tug at your heartstrings. And it's important to recognize that this is a commodity. There's also an industry of global health organizations that lobby Congress to continue funding in a certain way. Health system strengthening does not have those advantage of that marketability and that lobbying effort. However, if you are a health system strengthening, I believe is really a critical area to put energy in, and it'd be great to see more funding going for that. People are multidimensional beings, and we know that only about 20% of health outcomes are due to the clinical encounter, while most of the outcomes are due to social determinants of health that are outside the health field. We see this in this Robert Wood Johnson graphic, looking at county health rankings and their model, and the health impact pyramid, where socioeconomic factors are really the determinants of health outcomes and the sustainable development goals. In Zambia, our health budget was often the biggest. In Zambia, through PEPFAR, it was about $300 million. And we would often discuss with our development colleagues in agriculture, education, and financing that if we could give them half of our money, which we couldn't because the framework, the foreign assistance framework, did not allow us to implement well for 10 years, that we would probably see more sustainable health outcomes over the long run. So the multi-sectoral initiatives tend to be small, community-based initiatives like through PATH or other NGOs, or they tend to be social cash transfers. It's sort of a horizontal and vertical initiative at the same time. Or the European countries have traditionally, less so recently, given general budget support, realizing that when countries give to the health sector, host countries often move money out of the health sector to other sectors, which of course just makes sense. The last part of this pyramid is governance. And in my role, sometimes as CDC director, I was part of the US Embassy country team, the donor community, and interacting with senior ministry officials. And I realized quickly that most conversations actually centered around governance, and I needed to learn quickly. So I did a lot of reading, studied global health diplomacy, and talked to a lot of people. Governance is really the development lingo for the process by which decisions are made and implemented within donor or host country, and how conflicts of interest are managed, transparency, stakeholder engagement. This is a very important topic to be aware of and have some structural competency in this area, but too much to go into now. Is the two key messages I wanted to give were that it's really it's a symbiotic issue between donor countries and recipient countries. And we tend to hear a lot about corruption or governance issues in low and middle income countries, but it's really a symbiosis there. One statement I felt really captured that from one of my colleagues who is a seasoned USAID mission director. He was preparing for the 50th anniversary celebration of USAID in one country I was working in. And he stated that, well, our budget's a lot bigger than when we started and we've been here 50 years. Something must be fundamentally wrong with the system. And I don't think he was blaming either side, but I think he was acknowledging the symbiosis in recognizing that if they were successful, then they would have been they would have been working themselves out of a job. So to cut to the chase on the practical side, what I've noticed through my career is that some more promising approaches to avoid some of the areas in the pie chart in the beginning are working through effective multilateral initiatives, working in a short-term specific technical skill, for example, Operation Smile, this cleft lip and palate work, or where there's a specific need to fill in. Working in health system strengthening, especially healthcare worker or infrastructure programs, providing technical assistance to ministries or local institutions like the NEPI program, or doing relief work like Ebola. So hopefully this was a useful crash course. It could be a full semester course in what the many, many kinds of jobs in global health look like. But I want to turn back to how we engage or can best engage. And first, I talked about milestones, anti-colonial milestones. This slide here is some of the concepts are borrowed from the Structural Competency Working Group. And really, it's to just describe the challenge of structural competency, that everyone naturally grows up with a lens through which we see the world. And cultures, one definition of a culture is a way of seeing the world. When I see a tree and someone else sees a tree, we may be seeing completely different things. So when you're going overseas or to another country, the privilege that we have becomes a weapon to create harm. And this is something that invariably happens to any well-intentioned person and is unavoidable through much of what we say or do. So there's no neutral. The challenge is that seeing a foreign history, culture, or lived reality is really difficult. It requires a lot of unlearning for things that are more obvious for us to unlearn, and many things that are really hard for us to unlearn because we don't even realize that there are basic assumptions. So it takes persistent time and effort, but facilitates wonderful outcomes in relationships. Besides the anti-colonial milestones and structural competencies, there's a couple other levels of how we engage. Another one is recognizing agendas. This is a list of different kinds of global health organizations and some examples. Each come with their own agenda, as do we. And I came to believe that when I'm working in another country, I will always have an inherent conflict of interest. One example is when I was in Bangladesh, working with UNICEF on some safe water studies. I had a family emergency, and this was in 2005, and needed to return home. And even my colleagues in Bangladesh were saying, why are you here? Leave, recognizing that I wasn't with my family. And I left in the middle of the studies. And if I was local, I wouldn't have done that. So not being a citizen of the country inherently puts us at a conflict of interest. That's an obvious one, but there's many that are not so obvious. And they tend to result in behaviors and dynamics that can be slippery slopes and happen to the best of people. That could be doing something thinking that, oh, this may not be the best way, but it'll let me have more impact in the future. Or realizing that your organization is telling you to do something that's not quite right, but not really being open about it. Or focusing only on meeting targets at the expense of thinking about quality, or pursuing a career for a career over the right way to do things, or an expat lifestyle. So I think it's important to take time, mindful time, to sit and reflect for anyone, because we all have inherent conflicts of interest, in recognizing that. So how do you choose when you're going overseas? And the anti-colonial milestones could help when organizations, if they were to have those in the future, and I hope that does become a growth industry, to develop those. One other way is what one of my mentors told me, is to think about who is using who more. And I've always remembered this, that am I using an organization as a platform for my personal mission and values that I've really thought through and I'm comfortable with? Or is the organization using me for a mission and values that is really not aligned adequately with my mission and values? And one of my other mentors, when I first became a CDC director, said to me, know what you believe in, as her advice. And I thought that was quite simplistic, and I realized quite quickly it's much more difficult than I thought. And sometimes I still wonder about some of the situations I was in. None of us have the luxury of being in a perfect ethical environment in any profession, especially the US healthcare system, but we need to become proficient at making an informed, thoughtful, and ethical choice, and valuing that the constant struggle with that is what's important. So the last part of the pyramid that I think is really the most important is listening and allyship. Listening is key, spending as much time as possible with your host country counterparts. Listening to the point when you get triggered, when something's really uncomfortable, is when that's the opportunity to learn and change your assumptions. When that happens, you're actually forced into a situation of realizing there's no option except to speak up and become an ally. There are countless situations where I was in a room where something was being said and I realized host country nationals couldn't speak up because of their job. And they needed expat allies in the room. Even if the situation didn't change, they needed to know that. I like to remember that the word ambassador comes from the word servant, and we're all ambassadors when we're in another country. So in summary, global health is an exciting field. There's incredible opportunity for mutual understanding, transborder partnerships. There's greater recognition that the distinction between global and local health is really disappearing, which I hope continues. And this generation has opportunities to create change and start from a framework that wasn't there when I started. to do it well, we shouldn't shy away from it, but should really use our power to create good trouble when needed, be real change makers, even in this, especially when it involves some sacrifice. So thank you. I'd like to go ahead and turn it over to Dr. Malata now.
I don't know whether you can hear me.
Yeah, we can hear you. We just need to get your slides up.
Yes, I'll just I hope you can see the slides now. Sorry for the delay.
Yeah,
okay.
Looks great.
Thank you very much. Allow me to thank Sundeep for the very good presentation, and I think giving us a background of the topic that we're discussing today, redefining global health. And allow me, before I go into my slides, and I'll go through my slides very quickly, to share my life story a little bit, and perhaps to explain why global health is a critical issue for me as a professional living in a low-income country. So I grew up in Malawi, went to school as a little girl from a village, even without shoes. I struggled through school because of lack of resources, sometimes lack of fees. A missionary paid for my school fees for me to go to secondary school. I went to nursing college and did a diploma in nursing here in Malawi, and thereafter did a degree in nursing. And I wanted to proceed with my studies, but there were no opportunities in Malawi. So I had to go to Australia to do a master's degree, came back home, had 2 children, one 2 years old, the other one 10 months old, had to go back to Australia for PhD. Our youngest daughter at 10 months old was diagnosed with a sickle cell disease. And I only discovered when I was in Australia, and my husband was looking after our 2-year-old girl. Very difficult for me. And so when I returned to Malawi after PhD, because my daughter was unwell many times, I decided that I would work with my colleagues to come up with graduate programs within Malawi so that not every nurse should leave Malawi to go overseas for studies. Why do I bring this story to this discussion? It was not easy to get funders or international organizations or governments to support graduate training in Malawi, but also in many countries in Africa. So I remember first time when I went to the US Embassy to plead for support, I was informed there wasn't any funding for graduate training, and therefore they would inform me if there was any other opportunity, I think as we were waiting. And eventually then NAPI, Nurse Education Partnership Initiative, came into Malawi. And I was delighted that for the first time we train nurses at master's level and PhD level. It was not about degrees, but the quality of care. And I knew if we were going to improve nursing education in Malawi, we needed support for nurses to train here in Malawi and not to always go out of the country. And because my own experience with the 2 children, one in Malawi, one in Australia, and unwell, I couldn't be with my family, taught me lessons that it was important that we support nurses within Malawi. So I have been an advocate for global health, but also an advocate for support for within countries, that countries or people that are supporting low and medium income countries, institutions, governments should listen to what people are saying in that particular country. And NAPI was a true example of listening, because we were able to achieve our goals, not only for Malawi, we were able to influence even nursing education in South Africa, in Zambia, and Lesotho. So for me, a true success story of partnership that works very well. The impact of NAPI is still here today. I no longer lead the College of Nursing. I'm in the University of Science and Technology, but I've seen growth. Our profession in SADC region is much recognized now than ever before. And I do know that it has actually impacted the patient care. So the questions I always ask about global health and redefining is that, and I shared with some of the UCSF colleagues last week, is we still need to question the status quo. And I think issues of equity and justice are still a huge challenge. And I think listening to you, my colleague, as you presented, there are many questions that haven't been answered. And we continue to go through this trajectory, but I do believe that it's high time we start getting real answers that will make a difference to that local person who never goes to a workshop, is in rural Malawi, rural Zambia, and they don't have a voice to be on that table. And I think COVID-19 has energized this debate, because we've seen inequalities within countries, among countries, between countries, even for high-income countries. And I do know that we should still appreciate efforts. So efforts by academicians, students, researchers, civil society, and other organizations that speak for other people. So efforts are there, but we still have questions. And I like this quotation from Melinda Gates: when it comes to global health, there's no them, there's only us. And I think we need to reflect on this, because I think there are many issues that still happen that need attention. And I think in the previous presentation here, some of the issues that have been raised from the different programs, whether it was vertical, horizontal, and whether it has been approached using multisectoral organizations, but issues of economies are still a big issue. If you don't have the resources, you don't have a voice. And I do think it's high time that perhaps we started looking at issues differently. Economies should not always be the driver for global health. Let's look at what makes a difference in people's lives. Human resources for health. So Nurse Education Partnership Initiative is a big issue for Africa and a big animal. And I think we need to address these issues. So you can't talk global health without talking about human resources for health, because that's a key issue in the systems approach. And I think the presentation below explained very well about systems approach. Politics, we've seen politics. And I think many times people have always felt, okay, it's low and medium income countries that have got political issues in all senses. But I think issues that have happened in the past 2-3 years have actually shown the world that all countries in the world have got politics. And it's the politics that affects the care of global health, and also what we do in global health. Whatever we profess to wanting to do, politics is still there, and we need to, I think, start talking about these issues openly. And then, of course, technology. Technology is now a tool for improvement of care, but you can see the inequalities and the fact that even if you have technology developed in a low-income country, acceptability is still an issue. We still have to buy, equipment from, overseas, very expensive. And, these issues, at the end of the day, they affect healthcare system. And of course, the issue of collaboration, another big fight. The beautiful animals of Africa, but they represent big issues in global health. And then, of course, I'll not go into deep details because I think my colleague has talked about these issues, economies, and of course, the issue of how do we sustain a good healthcare system. And this also affects policies. Some policies that are made in countries are donor-driven policies. I don't think that every country in the low and medium income countries can really truly confess that all policies are really generated from the context within their countries. Many times it's about funding. And of course, clinical care. We've seen with COVID-19, education, curriculum that is still not context-based. It's high time that we really give autonomy to institutions to develop their own curriculum, context-based, and of course, research. And I really want to appreciate a project that we have with UCSF, my colleagues, Kesley and Jenny there. We have a program on ICANN. We did co-creation together, and we are now implementing in our countries, Malawi, Kenya, Uganda, and Nigeria, a true example of how you can actually, work together, but ensuring that people within the context are leading the research projects. And it's not always the case. Many times it's people that have resources, organizations that have resources, they come into countries, they do research, and sometimes even go out to conferences to present on behalf of countries, and they don't sometimes even appreciate the context. And I also want to say, I think, as I mentioned earlier on, human resources for health is still a huge issue. Can we still address issues in global health regarding human resources for health? Can we build local expertise? I don't think that enough is being done. You still find that, the books that are written, sometimes even publication doesn't represent context of low and medium income countries. Still a challenge there. And of course, issues of quality, maybe what is pushed into LMICs is not of good quality because people just want to push for numbers. And I want to say this very openly here. Many times when I've advocated for resources for healthcare capacity building for health workforce, many times institutions, partners are willing to give resources for scholarships or software, very cheap. But when you look at hardware, infrastructure, people will say, no, we don't go into infrastructure. So although we are going through a co-creation, many times you find that the co-creation is really about who is funding because they have the power to decide what they want to see happen. And then, of course, this is just showing you how it's always very important that we always reflect back on where are the diseases happening. And I do know that COVID-19 has changed perhaps how we look at things now. But when you look at this slide, where you have so many people with diseases and the global disease burden is very high, like, for example, there in Africa, you find that the percentage of global workforce is very, very low and a mismatch. It should have been the opposite. But we can't discuss global health if we don't address this issue. And how do we address this issue? Let's build local capacity, not bringing projects that will last for 2 years, 3 years, and no sustainability. Then we are not making a difference. And this is also just showing the fact that where there are diseases, there are few health workers, and we need to improve this. I was checking on the WHO website whether this has changed, but this has been the case actually for I think I'll say over 2 decades. And then, of course, the issue of survival. I think when you have health workers, people will survive. So whatever, I know that I'm focusing on this is because this is my area of expertise, but I want to emphasize the fact that although people know, institutions know, governments know, international organizations know that health workforce make a difference in a country, there's still a lot that needs to be done to improve on equity and, of course, access as well. And then, of course, politics. I talked about politics earlier on, issues of transformative leadership, and I think was emphasized by my colleague. we need to build capacity for leadership within countries, within regions, so that people can take leadership and give direction to projects. So NEPI, we were given that opportunity to make those decisions for our countries, and that's why there has been sustainability. The resources got finished, but I can truly say even today, Malawi is training nurses at master's level, PhD level, different areas, and we've been able to train even other countries how to do things in terms of education. Innovation, technology, I'm now in a University of Science and Technology, and I do believe that global health has got to address issues of registration in innovation and technology. COVID-19 has taught us lessons, and Africa has shown that it has potential to innovate, because there were days when you couldn't get any resource from anywhere. Our own universities came up with innovation, but can we build local capacity? Can we accept indigenous knowledge? Can we give more funding? And of course, scaling up, not just small projects that will last for a year or 6 months. Collaboration back, this is a basic issue, and yet all still, we don't say a win-win situation. Nelson Mandela said, if you want to go far, and far to me is sustainability, let's go together. If you want to go very, very fast, which is normally the case, then go alone. And that's what happens. So although on paper, you'd be like you are in a team, you're working together as partners, north, south, 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 north, north. But at the end of the day, the reality of the ground is that people are running on their own, and therefore we don't see much impact. My reflection is leadership. We want to be on that table. We want to make decisions. We want to choose the menu on the table. It doesn't always happen. And as a teacher, what I do now is to encourage young people that are coming after us to say, if they don't invite you, invite yourself on that table. Use of local language. Also, of course, use of experts to tell stories. We need to tell our stories so that once we tell our stories, then decisions are made to meet the needs of the specific context. And of course, I already talked about policies and legislation. And of course, we need to encourage good collaborations, win-win situation, mentorship, whatever is happening. So UCSF colleagues, when you are working in any country, ensure that you leave someone in that country that can continue with the program. So mentorship should be part of any co-creation, not at the end of the program. So you know you're finishing in 2 months, then you want to bring somebody on board. No, it should actually be part of whatever we do so that we can make a difference. And finally, as I finish, I think we all know this. There are a lot of emerging issues, research deficiencies, vaccines. I want to emphasize vaccines, because COVID-19 has taught us, I think, a weakness in global health. The fact that we only have few countries that can produce vaccines, the fact that we are not building capacity within countries. There was a day in Malawi where Malawians were fighting to get vaccines because there was nothing in the country. And I think it's unfair. It should not happen in this century. Then finally, my last word, take-home message for all of us that are on this panel, and of course, colleagues that are listening, that we need to rethink our strategies. If we're going to talk about redefining, then let's rethink strategies, because I think we've been talking about these issues for a long time, but perhaps we don't make as much progress as I would think we should have made. There should be better coordination, co-creation in a true sense, and of course, there should be true investment. Investment that does not get people into countries. So you get a project, you have all technical advisors from the US, from the UK, and then you have very few people on the ground. So after funding is finished, everything goes back to that high income country. I think we should not allow this to happen. Let's make a difference. True investment. I think that's something that we need to think about. Thank you very much. I do know that I've rushed through the slides, but I was very mindful of our time. And thank you very much for having me on this panel. Thank you.
Thank you. Thank you, Dr. Malata and Dr. Gupta, for your phenomenal presentations with so much for us to think about. Jason, I want to make sure that you have time to share your thoughts with us too, or maybe ask one question. We don't have a lot of time left, but we have a little bit.
Yeah, it looks like we have a question in the chat. Yuri Cartier asks, what lessons from anti-colonialism movements in African countries do you think oppressed people in the US could learn from and apply?
Dr. Matalata, do you want to take a stab at that, or would you like, you might be better positioned?
I think Jason can go first.
Or I can start. I think it's a very good question, difficult question. I think it's the question expresses that there's a lot of similarities. It's sort of the global-local divide having decreased that between anti-colonial and anti-oppressive movements. I feel like there's been a real framing in the US that in my presentation I was thinking could be used overseas, but I think the question really gets to there's probably a lot from the aspect of lessons from low and middle income countries for high income countries that could be applied. But I'd have to think about exactly what some of those best strategies could be. I'm sure there must be.
Thank you for that. Thank you for that thoughtful response. Dr. Malata, would you like to have the last word in answering this question, because we're getting close to the end, and I would love to hear your words of wisdom for all of us as we close. Thank you.
Yeah, I think for me it's a very very critical question, but maybe for my last comment to just say, I think in all this what we see is just making sure that people listen. I think voices make a difference, but making, you can speak, you can express your wishes, you can express your opinion, but if no one listens, you can't make a difference. And I think we can do better if there was just a little bit more listening. And to me, even with the question that's been asked, the issue is about listening. And also, of course, I want to say that there should always be sustainability at the back of our minds. Whatever we do, is this sustainable? When funding is finished, when you're not there, can people look back and say this was worthwhile? And I always believe that, I think at the end of the day, everyone, each one of us, in whatever role we are playing in the healthcare system, we should always be asking ourselves, when everything is said and done, what difference did we make in Malawi? What difference did we make in Zambia? What difference did we make in Kenya? Because it's not publications. It is not about, becoming a professor or becoming, an adjunct professor somewhere because you have done so much work, but the difference you make in people's lives. And I think Sundeep is a very good example of someone who was very committed in Malawi. And I do remember that he was listening. And I would want to see as many of colleagues from the US and other parts of the world in high income countries go into LMICs and listen, but also get people on board and get them on the table, and don't decide for them. They know what can make a change in their country, but at the same time, you also want to make sure that you're building local capacity. And many times people claim they build local capacity, but they don't. It's usually people that are just sitting around and they're still driving the agenda. But it's about economies, as I said earlier on. If you have resources, you have more word to say, you have more power. But let's remember, making a difference is what we need in this world. Thank you.
Thank you to all of our speakers, to Dr. Gupta, Dr. Malata, Dr. Chen. Thank you for joining us. And thanks to everyone here who's participated. I think the lesson of listening and the words of wisdom will stay with us for a long time. I would encourage you, if you have questions, to reach out by email to any of our speakers. And I appreciate your joining us. If you are interested in watching previous Grand Rounds, they're on the website, and we hope to see you next month. Thank you so much. Have a great afternoon.
Thank you.